And now I would like to ask Polina from Hadassah to come to speak a little bit about our Hadassah experience about BMT in was. Polina, please.
Thank you very much for giving me the opportunity to present our Israeli data about transplantation in Wiskott-Aldrich syndrome, and my personal thanks to Lisa, because I learned a lot from your speaking, and I learned a lot previously from your work on Wiskott-Aldrich syndrome. And this is not only Hadassah experience, this experience from all Israel, from all our country. And I want to start with something from history, Sir William Osler. And you know, everything usually started with patients. All our learning of medicine, continuing of learning, and it's all time we are working with patients. And also all this story and my interest in Wiskott-Aldrich syndrome was started with one of my patients, and it was the beginning. It was really, really difficult diagnosis and really, really difficult decision, because he was a 4-month-old boy who was presented to our emergency room with thrombocytopenia and significant hepatosplenomegaly, and he was diagnosed as suffered from congenital CMV infection, proven by gut recart, and it was the diagnosis. But he was not improved during, I think, 3 or 4 months of hospitalization. He was treated by ganciclovir, nothing doesn't happen, and we asked him, maybe he has Wiskott-Aldrich syndrome. And it took a long time because he was hospitalized in the pediatric department. And on the day of diagnosis, because the people from the pediatric department, the physicians sent the blood for Wiskott-Aldrich syndrome protein expression, and we saw reduced expression, and they told me, okay, you have to go and to meet the patient, and I came to the department to meet the patient, and I saw that something happened. What happened? He developed significant retinal hemorrhage on the day of diagnosis. And everybody told me, what do you want to do with him? You know, and for me it was clear that we have to transplant him, but my question was how to transplant him, because he had not any matched donor, he was the first child and no siblings and no match unrelated donor. And I started to think what to do with him. And this is the outcome of my decision. And now he is, I think, 3 years after transplantation. He was transplanted with umbilical cord blood, and this is very, very interesting and unusual, because he developed retinal hemorrhage not from thrombocytopenia but from CMV infection. And he was checked by our ophthalmologist before, but nothing was not seen. Why? Because he had not normal immune system. And when we transplanted him, we saw immunological response in his eyes. And we did also vitreous body biopsy, and we checked for CMV status. And it was more than 2 million copies of CMV in his vitreous body. When in his blood, he had non-significant viral load, nothing. And we learned a lot from this case, and I thought from one of our young physicians from pediatric department, we have to write about it, because I think it's really interesting and unusual. And we published our experience about this child, and I asked it, what happened in Israel, you know, because I feel myself very, very not experienced, and I thought about something, that we have a lot of primary immune deficiency from consanguineous families, but Wiskott-Aldrich, it's not dependent from consanguinity, because it's X-linked diseases. And I tried to collect data about Wiskott-Aldrich syndrome, transplantation for Wiskott-Aldrich syndrome in Israel. And we found 14 patients with severe Wiskott-Aldrich syndrome phenotype who underwent hematopoietic stem cell transplantations at 4 Israeli centers. And I want to thank to all my friends and to my colleagues who gave me this data. And that's what we have in Israel. In Hadassah, we transplanted 6 patients, in Tel HaShomer 3 patients, in Schneider Medical Center Petah Tikva 4 patients, in Rambam 1 patient was transplanted. And here you can see data about the presentation of these children. Thrombocytopenia and eczema was seen in all of them. Previous infection in significant number of children, significant hemorrhage or autoimmune phenomena in 50% of these patients. And 10 children, they received any medical treatment prior to transplantation, like corticosteroids, IVIG, rituximab, but none had undergone splenectomy. And age of transplantation was ranged from very young age to 6 years. And Lansky score, this is a score for performance status, less than 90 was recorded only in 2 children. And that about the grafts, because these children came to us not from consanguineous family. We have a lot of children who were transplanted from alternative donor. Only 4 children were transplanted from matched sibling donor, 1 from matched family, and 3 children from matched unrelated, 4 umbilical cord, and 2 children underwent haploidentical transplantation. In the and bone marrow and peripheral blood, this is according to preference of a transplant center. And a few words about the conditioning, because not all of you are transplant physicians. We have some hierarchy of commonly used minimal intensity, reduced intensity myeloablative conditioning. And this is myeloablative conditioning. This is reduced intensity, when we try to reduce the toxicity of our preparation. And here in Israel, we have a long history of reduced intensity conditioning, and it was started in Hadassah by Shimon Slavin a long time ago. And we tried in Israel to transplant a lot of our children with fludarabine-based reduced intensity conditioning. 6 children were transplanted with classical busulfan cyclophosphamide conditioning, myeloablative, and 8 children were transplanted with fludarabine-based reduced intensity. Neutrophil and platelets engraftment. All but one patient achieved engraftment, and the time was, as accepted in all our publication, the median time for ANC and platelet engraftment was 23 days and 38 days, respectively. And something interesting, but it's well known that for cord, the time for engraftment was significantly longer. Graft versus host disease. 4 children developed GVHD, grade 2-4, skin and gut involvement. All of them were treated as usually steroids, calcineurin inhibitors, imicofenolate, mofetil. My patient, who I described previously, he developed hyperacute GVHD that developed even before engraftment, and he was treated with all what we have, steroids, cyclosporin, imicofenolate, mofetil, and I gave him also mesenchymal stem cells with very good effect, and you saw him now. Chronic mild limited GVHD developed only in 2 children without any impairment in quality of life because it's limited and not significantly clinically. Not significant clinically. It was okay, only 1 our child was died. It was long time ago. It was in 1994 in Hadassah, and the child was he was the oldest our patient, who was more than 6 years old. He was transplanted from his uncle and developed primary graft failure. He was not engrafted. Subsequently, he developed sepsis and unfortunately died. But 13 out of 14 patients are survivors. But as Lisa told, we are dealing not only with survival, we are dealing with quality of life. And what does it mean, quality of life? It was much more important for me. What is the probability of event-free survival for all these children? And we decided what we can analyze. What is disease-free survival? We had to define what does it mean for us events. Death from transplantation, secondary graft failure, and mixed Hemera state that led to residual autoimmunity, thrombocytopenia, or second hematopoietic stem cell transplantation. And that's what we have. We have close to 60% event-free survival, and we tried to see what affect our disease-free survival. And we saw that it's not influenced by donor types. Okay, here it's not significant. Alternative donor or classical matched family, matched sibling donor, it was not affected by it. But it was affected by the type of conditioning. Because as you can see, with reduced intensity conditioning, we have significantly low disease-free survival than with classical myeloablative conditioning. And our conclusion, and 2 patients who were transplanted from haploidentical donors, and they were transplanted by reduced intensity conditioning. They survived, but post-transplantation autoimmune phenomena occurred. 4 children who were transplanted from umbilical cord survived with 100% donor chimerism and without any significant long-term sequelae. And as expected, as I told previously, these children experienced relatively delayed engraftment. And we saw here a high survival rate, even in patients who were transplanted from alternative donor. And we saw as well significantly better disease-free survival for patients who were transplanted with full myeloablative conditioning. 2 children who failed first transplant were conditioned with reduced intensity conditioning. And the use of alternative donor like umbilical cord was not associated with reduced disease-free survival. And I want to thank from all my heart to my colleagues and to my friends from all hospitals in Israel who gave me this data and who shared with me by their experience, and my personal thanks to all these children who taught me what does it mean transplantation. Thank you, and thank you for your attention.